Good afternoon. I would like to thank the organizing committee for inviting me again to their course. This is a continuous course by two exceptional scientists, and that's Ms. Savivu, Professor Savivu. That's a very good surgeon and a very good friend, and also Savas Surmelis, which is one of my mentors. And I'm obliged to follow any academic and scientific movements that he does, because he's my mentor. So I will talk about radial head arthroplasty, which one to choose, press fit or loose fit. Radial head fractures, it accounts for 5.4% of all fractures. It is involved in 1/3 of fractures of elbow and trauma of the elbow. Now, treatment, and that I just put it there to connect with the other speakers. What we do, Mason-free fractures, they're controversial. We usually try to fix it. If it's impossible to fix it, then we do an arthroplasty. And in treatment of Mason 4, we do an arthroplasty, not a resection, because an excision may lead to progressive valgus instability, potential radial ascent, degenerative changes in the elbow joint, chronic MCL laxity and pain, and sometimes ulnar nerve neuritis. So if we see the biomechanics, the more modern biomechanics of the radial head, more than 50% of all the radial heads were elliptical, 43% were circular. So the neck shaft angle also differentiates regarding to the shape of the head, and the biomechanics also are different. More or less load is passing through the radial head depending on the shape. So we now have more modular anatomic designs, which give more intraoperative options, potentially better function and survival rates. But we have new complications that have been arise, and still they're not truly anatomic. Has changed a lot since the beginning, the radial head arthroplasty, design, materials, but we're still in search for the perfect design. So there is a lot of diversification. We have anatomic, non-anatomic, press fit, loose fit, monopolar, bipolar, short, long stems, different materials for the radial head. This is one of the first meta-analysis paper, which include all kinds of different prostheses, different types of fixation to the radial head, and different follow-ups. But at the end, trust me, we can see, but it's a very thick slide. We can see that press fit has, in some papers, 0 revision rates, and in some papers it has 29%. The same happens with the loose fit. It can have, in some series, 0%, and in others, 28%. So the MEP score in this meta-analysis and the other functional scores are not constantly reported, so there is a difference between the papers. Almost all the papers have excellent and good results, up to 85%. Outcome for all fixation techniques, they're between good and excellent. So which one to choose? We're still in that section, and we have to see why the head of the radial head arthroplasty fails. And it looks that 8%, it's the mean revision rate of it. The causes primarily is painful loosening, and here we have to define, is it pain with loosening or is it painful loosening? And sometimes it's very thin to understand the difference. Other causes are overstuffing, instability, and etc. So if we see who is responsible for a failure of a radial head prosthesis, is it the implant, is it the surgeon, or is it the trauma pattern of the injury? We will see that in painful loosening, and if we have a loosening, we have radiological complications like stress shielding and bone loss, then it has to do with the implant. But all the other cases, they're more related to the surgeon and more related to the pattern of the trauma. So there are different ways of thinking, because we say that the most common complication is the stem loosening. There are two ways of thinking. The spacer kind of thinking, with loose fit prosthesis, easy to use, spacer will also transfer loads. There is, of course, no stress shielding, no loosening, although we'll see from the papers that we have lines of lucency even in the spacer kind of prosthesis. The arthroplasty kind of thinking, press fit stem, like we do in all our arthroplasties, rigid fixation, reconstruction, somehow closer to the original anatomy, but not exactly the same. Radiologic findings with stress shielding or radiolucencies, we found them very commonly, but do they affect the overall result? So literature is available for favor of each of the two kinds. You can find literature supporting press fit or supporting the loose fit. There is a trend nowadays in favor of loose stem implants in terms of survival rate. I don't know if this is because we're going to the right way, or is it because we don't have good fixation for the stems of the arthroplasty and of the spacer. We'll see that. Not many studies are specifically designed to compare the two. So here is a paper from 2019 which compared the effect of the stem in the radiocapitellar contact. And we see that loose, smooth stem implant may be functioned like a bipolar implant because it moves in the radial canal, so it can take a few angles, optimizing the radiocapitellar contact. But nobody has stated how loose this would be. Should be 30% of the canal, 20, 10%. Nobody has decided on that, and we need to decide if we say a spacer is the solution. So here is another meta-analysis and systemic review with a lot of patients, almost 900. You see there is quite a difference between the one that they use fixed prosthesis and the one that they use unfixed. And also there is a gap in the follow-up of about 9 months. And we just have to keep that in mind. In this paper, the scores were similar for both fixed prosthesis and spacer. And the revision rates were almost double, more than double, in the fixed prosthesis. Complication rates were almost double in the fixed prosthesis. What is stated in the paper, though, is that fixation type does not appear to affect functional outcomes. And the rigidly fixed implant may increase the risk of revision and complication, on the other hand. There is a comparative prospective study in the literature for complex acute elbow instability with long-term clinical and radiological outcomes with 46 press fit and 49 loose fit prosthesis, which you can see that there are different indications for using the prosthesis under where we say complex acute elbow instability. So they're not the same pattern of trauma. They don't have the same pattern of trauma. So we see that implant removal was in 8 patients in the fixed prosthesis and in 1 patient with a spacer. Radiographically, there were more complications, if we can say radiographic complications, in the group with a press fit and less complication, but still we had loosened lines around the spacer prosthesis. There was no difference in range of motion, of scores, of pain relief, but in the paper it stated that patients with a spacer showed a higher degree of satisfaction. Okay? Now, if we see closer the 8 failures of a fixed prosthesis, we'll see that 5 of them, they were not because of loosening. They were because of wrong decision by the surgeon and maybe the trauma pattern that gave the stiffness. So there is the loosening paradox. Revision is common for loosening, but is loosening always a problem? Is the pain from the loosening? Do radiolucent lines affect outcome? Literature constantly suggests radiolucencies and loosening do not affect functional outcome. And they're not only found in press fit, as we said. Now, this recent study in 2023 suggests significantly higher loosening in cases with a bilateral ligamentous injury. So the trauma pattern must play a major role in painful loosening or loosening with pain. And spacer fans argue that press fit implants tend to become loose, but the implant loose fit prosthesis. And that's a joke, a logical joke. So, probably it does not exist. Yes, it does not exist yet. No concrete evidence to support one type of radial head prosthesis over another. 90% of current literature, insufficient follow-up, underestimates the rate of failure. Studies with inherent bias and small sample sizes. We need better studies, indications to be written in the studies carefully, the trauma pattern, the reasons of failure, and other factors that will contribute to a better study. And we need to take the radial head arthroplasty, if we're going to use it and not just use a spacer, more seriously. After all, it's an arthroplasty. No other arthroplasty implanting technique is that much surgeon-related. Radial head cut usually performed freehand in most cases. But in what height, in which forearm rotation, in what cutting angle? No other arthroplasty is performed without specialized cutting guides. Anatomic design of radial head arthroplasty should anatomically fit into the radial canal and not just put a stem in the canal. Special cutting guides should be designed and commercialized. And the future, we have some hopes because there is a computer-assisted optical tracking device that they're developing, and this is in vitro, is not commercialized yet. We can say that patient-specific implant, it can be used, easier to set that down, many parameters to take into account, and of course, if you're going to use this kind of prosthesis, you will need a patient-specific insertion technique to use. And there is another paper, small but promising series, with a 3D printed porous tantalum, and we have an instrumentation also that comes with it as a special custom device. So in conclusion, almost every radial head arthroplasty seems to work all right. Loose fit implants seems to outperform press fit implants in terms of survival. Radiographic findings not always correlated to clinical results. Trauma pattern parameters might affect radiological findings. Evaluation of radial head arthroplasty, for radial head arthroplasty should be mostly anatomic, must continue starting with a more standardized implanting technique. Thank you very much.